اصلا يعني مقدم و يعني واحد من يعني our talented colleagues اللي حاليا world wide reputation، واعتقد الكل يعرف دوره بالانترودكشن مال الاوستيو انتجريشن وغيره. وين يشتغل؟ اعتقد دكتور منجد اعتقد باكثر من مكان، يعني بمكواري يونيفرسيتي بالنور ويست، واذا اكو مكان اخر انا ما ادري موجود وين.
I work in different places. East Sydney Private and the Sydney Adventist Hospital. Which اشتغل بهيرسفيل هم يعني. But I work only in the private sector. I don't work in the public sector.
بس ايضا نور ويست ومكواري مو صحيح؟
Macquarie, Northwest, East Sydney Private in the city, and the Sydney Adventist Hospital.
Everywhere. فأهلا وسهلا، شرفتنا دكتور.
Alright.
بالمناسبة دكتور منجد هو رئيس جمعيتنا، هو رئيس الجمعية الطبية العراقية الأسترالية نيوزيلندية، هو الرئيس. نعم.
أهلا وسهلا، شرفتونا جميعا. دكتور منجد, he kindly will talk to us about perhaps an update about the hip disorders and what is related to his subspecialty. Very kind of you that you shared that nice webinar. We've been all waiting for that. Perhaps I'm not the youngest, but one of the youngest, and I started to have some back pain, so I'm very keen on personal level. Dr. Munjid, would you please go ahead? I'm not sure if we have shared screen with you, if you like. I'll just allow.
Yeah, I mean,
would you mind?
Yeah. So I'll start my talk.
بلي. احنا بس اقتراح كان الاتفاق انه الكيو ان اي تكون at the end of the session. each will have around 15 minutes introduction presentation, بس الكيو ان اي يكون بالاخير. هي كان الاقتراح. بلي.
We can see your screen, Dr. Majid.
Perfect. Okay. Are you happy if I start?
Yep.
Please go ahead.
Okay. Good evening, everybody. Thank you very much for having me here. I'm Munjid Almderis. I'm a professor at Macquarie University and a professor at Notre Dame University, and both the Faculty of Medicine, and I'm an honorary professor at Sydney University, Faculty of Engineering. So I hold some academic titles, but my day-to-day work involve standard arthroplasty in hips and knees, but I have special passion about major reconstructive surgery. So I lead the discipline of deformity and limb reconstruction at Macquarie University, and as part of that is the technology that I participate in pioneering in osseointegration surgery for amputees, and that gained reputation worldwide. So that's a brief description of what I do on day-to-day basis. I do have several disclosures, as I do participate in design and manufacturing of several products, including the osseointegration device, and I own a company that runs the manufacturing of and the design of many orthopedic products. So normal hip anatomy. Hip anatomy is composed of a ball and socket joint. It's one of the most constrained joints in the body. A joint is, by definition, is an articulation between two or more bones that are shaped in a structure, whether it's a ball and socket, whether it's a saddle, or it's a flat-on-flat surface. These bones are covered with a very thin surface of a smooth cartilage, and the base of the joint is basically lubricated by synovial fluid that is secreted by a synovial membrane. The joint usually is supported by either the structure of the articulating surface bone, or they are supported by ligaments that are static to support that joint, or they are driven and actively moved by the muscles that operate this joint and provide an active supporter. So that's in summary what a joint is. When it becomes arthritic, the joint lose its basically one or more of its characteristics, such as the space of the joint narrows, the cartilage is destroyed, they start to form deformity in the joint, and the smooth round surface structure changes to become more like rectangular or flattened, and subchondral sclerosis forms and osteophyte formation forms, and then you can see that the shape, it looks different than the normal joint. So basically, when a person feel arthritic pain, it's either a dull or aching in nature. When it comes to the hip, majority of people feel that their hip joint is around the trochanteric region. That's not the case. It's that the outer pain on the greater trochanter. The pain of the arthritic hip is usually in the groin, and sometimes, very often, it goes into the knee joint, and or comes from the back itself. So back pain can be a hip arthritis. Knee pain can be hip arthritis. So it's very important. Sorry, can you hear me?
We can hear you very well, actually.
Yeah.
May I just ask everyone
Yeah.
to mute themselves, just for only speaker, Professor Al-Mudarris.
Yep.
Go ahead, please.
Sorry. Yeah. So it's very important when you get presented with a patient with back pain or knee pain to remember that, or be mindful that it could be coming from the hip. It's very often that we see cases that have had a knee replacement done, and even a revision knee replacement, and the surgeon have operated on the wrong side of the body, which is basically operating on the knee while the hip was the source of the problem. Usually pain is worse in the morning after sitting or resting for a while, but it lessened with activity. And that's because when you move that joint, the surface lubricates, and then the pain and the body release some endorphins, and patients can tolerate that more. And then night pain is important. Pain increase with stiffness and usually with vigorous activities. So it is important to send patients for physiotherapy to get their range of movement and muscle power, but then excessive physiotherapy can be counterproductive and can cause more problems rather than benefits. Pain in joints severe enough cause limp and walking difficulty. And one thing you can notice is that people can start having difficulty going upstairs, downstairs, and getting in and out of a car. So how to treat hip arthritis? Bottom line, hip arthritis, the ultimate treatment for it is a hip replacement. Hip replacement is the second most successful surgery that ever invented after cataract surgery. But to buy time, for one reason or another, if you have patients that are very young, you can give them pain medications. You can optimize their rehabilitation by giving physiotherapy exercises. Losing weight is very important. That can help with the pain. And you can use temporary measures such as steroid injections and plasma-rich protein injections, but they don't work basically on the long run. So when is the right time to refer to an orthopedic surgeon? If the pain becomes constant, if the pain is all the time, if the pain affects the day-to-day activity, and patients are worrying about the journey that they're going to take to go to a restaurant or anywhere they want to go to, if the pain grab you when you put your shoes on, getting to the shoes is a big problem. When patients suffer from severe arthritic changes in the hip, and if their sleep is being affected. So what type of treatments do we have for hip replacement? From the surgical perspective, we have partial hip replacement, total hip replacement, revision hip replacement. Partial hip replacement is no longer used in the vast majority of clinical applications. So I can't recall the last time I've done a half hip replacement. Usually it's reserved for patients who are
Dr. Munjid, Afwan, you are muted all of a sudden.
Can you hear me now?
I can hear you very well. Yeah, I'm sorry.
Yeah.
I'm not sure why you have been muted. Yeah, go ahead.
That's all right. I'll be mindful of that. So total hip replacement is usually the standard method of treatment for hip arthritis. And when total hip replacement failed, you can do revision hip replacement. So the factors that affect the outcome of any joint replacement, it depends on three elements: the patient, the surgeon, and the technology. And these factors are equally important. So when we come to the patient, you have three types of patients, basically. And this is my philosophy about arthroplasty, basically. You have the best patient, which is a young, healthy female. And they are the best patient that you've got because they are wise, they're smart, and they're not going to do anything stupid. And they have a good frame that you can work with. Then you have the second patient, which is the second best patient. It's a male, whether young or old, basically. And males usually are less predictable when it comes to outcomes of surgery, and that's because they are weekend warriors. When you fix their hip problem, they go on a war. They try to get to the backyard, dig holes, build walls, and jump from the wall to the hole and fracture their legs. So they are not as smart as females, but they've been given the ability to have a strong platform because their bone's stronger. The worst patient is osteoporotic females, and that's when females become elderly. That is a problem, and that's why I prefer, when I do my arthroplasty, I prefer them in younger females than older females, because no matter how good is the surgeon or the technology, the outcome will be affected adversely because of the nature of the bone for elderly females. Surgeons' experience play a major role, and it is very important to see that with numbers, surgeons basically who perform larger numbers of arthroplasties, they are the ones who have the least complications. And funny enough, this data is from the Joint Registry. A lot of surgeons inflate their numbers, but factually there are only 4% of surgeons in Australia that perform more than 70 joints a year, basically. And the vast majority of surgeons, nearly half of the surgeons in Australia, perform less than 10 joint replacements per year. And you look at the statistics here, you can see that surgeons who perform larger numbers, they have the lower complication rates. And then you move on to the technology. With the technology, we don't basically know which approach is the best. There are posterior approach, there are direct anterior approach, there is superpath, there is lateral approach. None of them are new. All of them are have been there for a very long time. And bottom line, the best approach is the approach that is done by someone who knows what they're doing, basically. And the aim is to optimize the visualization, have a reproducible effect by the surgeon, and less invasive. And when I say less invasive, not meaning smaller cut, but less traumatic to the tissue, and allow the patient to have rapid postoperative recovery. And these are the goals of any good outcome of any surgery. I do anterior approach, and anterior approach, when we started doing it many years ago, we were criticized very heavily for it because people accuse it of technically challenging. As a matter of fact, if you do many of them, it becomes very simple, straightforward. Harder visualization, I mean, it depends on any approach. You can make any approach very hard to visualize if you're doing the wrong thing. you require a special table. I don't use a special table. I use the standard table, and intraoperative X-ray is needed. That is one of the basically criticism about anterior approach. As a matter of fact, intraoperative X-ray is very important. Because I can check the position of my implants intraoperatively before the patient go to recovery. So it's an advantage rather than a disadvantage. Fracture risk increases. That is true with regards to the femur, especially in experienced surgeons, and people say that it's not suitable for deformities. That is not the truth, basically. Usually it doesn't take that long. On average, it takes less than an hour to perform a hip replacement in the hands of experienced surgeon, whether you're doing it anterior approach or posterior approach. And patients, usually that is true comment that patients do as well if you have anterior approach or posterior approach. One approach that I strongly believe that it's not the ideal approach is the lateral approach. That's very old fashioned approach where it involves cutting all the muscles, and not many people are using it. Lucky, like the surgeons that use this approach are all retiring basically. So this is the incision that you can see. The position of the cup can be visualized, and the stem, and the patient is lying supine, basically flat on the table, and you can perform the operation without cutting any muscle. So the approach for the hip is from the front. It does not disturb any muscles. It causes minimal trauma to the tissue. It's muscle sparing, and it's smaller, basically incision. Now we have additive associated basically instruments and guides that help us with achieving what we want to achieve, and that's what we're doing now with CAD modeling and basically optimizing the patient planning before the surgery. And what we do now, we do CT scanning for all these patients, plan the surgery beforehand, and design the optimum approach for the patients. And you can see you have all these measures. And before I perform the surgery, I know upfront what size of implant I'm going to do, where I'm going to position the hip, and I can check it intraoperatively, basically for these patients. And the aim is to get a predictable outcome for these patients and have good results. As you can see, this is an example of a patient that Mustafa did with me. Basically, actually, Mustafa did this operation, not me. And the patient is like 1 week after the surgery, and she's walking unaided. And then you go to some complex cases that can be done through the anterior approach, like this patient, for example. This patient has been treated with Gerlson for 30 years, and he's been to so many doctors, and he's been told that there's nothing can be done for you. But he can reconstruct this this patient basically by proper planning. We did plan the surgery. We manufactured the jigs for him and the established shell, and used a customized tumor prosthesis implant for the patient. And he regained his length as well as his mobility. Complex cases, considering we're coming from the Middle East and from the Arabic background, we see a lot of neglected hip dysplasias like this patient. With the additive technology that we have with CT scanning and 3D modeling of these patients, you can achieve this through anterior approach. Basically, you can see the pre-op and the post-op X-ray, and the patient has regained the ability to mobilize much better. So there is a lot that you can do now with the current technology. This is a patient who had septic arthritis on top of multiple exostosis, and we had to stage his surgery. Basically, we put a cement spacer in order to clear his infection, and then Mustafa planned his shell basically, and we managed to implement a great hip replacement for him basically, and he regained his mobility. And then it gets more complex. All of these I've done them through anterior approach basically. I inherited this patient who has had multiple surgeries, pouring pus from her leg, severely infected hip replacement, had several surgeries, as you can see, and with broken metal everywhere, and positioning the implant, the surgeon who did it positioned the implant in the wrong place. So we managed to get her back, clear the infection, and give her proper mobility back, basically. And potentially we're embarking on doing the other side. So basically what you can see here from the registry results, that there are the main complications of hip replacement are either dislocation, and to be honest, I mean, after doing a few thousand of these hips, I have only 3 dislocations. But whether that is related to good technique or because I use the anterior approach, I'm not sure. But this is one of the advantages that I claim, that that has lower risk. Loosening and of the stem and the cup, that's another complication that can occur in any patients, and failure of the implants. And basically, it is more likely to happen in the early days with cementless hip replacement, but it's less likely to happen or it's more likely to happen later on down the track with cemented hip replacement. But with proper planning, that basically is less likely to occur. So with recovery, patients usually walk the next day. They can swim after 10 days. They walk with crutches whenever they are comfortable to get rid of them, and they return to driving basically in my patient cohort whenever they are comfortable and they have control. So sometimes up to 1 or 2 weeks. So in summary, I would recommend that people should consider a hip replacement if they get constant pain. Age is just a number, because the youngest hip replacement I've done on a 15-year-old, because if they need a hip replacement, they need a hip replacement. There is no age that is good or bad for a hip replacement. Is the timing is when they have constant pain, when they have pain that affects their day-to-day activity, and when the pain affects their sleep, basically. Thank you very much.
Thank you very much, Professor Mudarris. That was nice, quick, and very informative. I think we're all privileged tonight by having not only 4 senior speakers, but also very good attendees that reflect the high interest of our group. For the sake of the time, I would like to move next to Dr. Yasser Al-Khatib and to talk. We go a little bit below the hip now, go to the knee. So hopefully Yasser will help us to introduce himself to everyone, if you don't mind, Yasser, and to go ahead, please.
Hello, good evening. Can you hear me?
Can hear you muffled a little bit, Yasser. First of all, while you introduce yourself, perhaps I will ask as well to share your screen and keep on going. Hopefully hear you better.
So I'll try to share my screen and hopefully that works. Is that working for you guys? Can you see it?
There is an echo, Dr. Yasser Azizi. There is some echo with your voice coming.
Oh, okay. I'll try to, is that working better? Is that guys?
Not really. Still, like we can hear a clear echo, perhaps with affect the clarity.
Okay.
Yeah.
Any suggestions? I'm not quite familiar what to do with it.
Is it related to you're not using basically any headphone?
I'm using the audio on the computer.
Yeah.
Maybe
sure.
just make sure that you don't have phone and laptop on at the same time.
No, only the laptop. Let me try to, I'm not sure what to do.
Yeah. Do you think you can try perhaps attaching a headphone, see if that gets it better? No idea.
Okay, well,
any idea, Dr. Ahmed?
I can try to get some headphones if that works better. Would you like me to do that?
Yeah, we can certainly see your screen, but yes, if you can just improve this sound a little bit, then yeah, say lots of comments from the audience saying that echo. So
why don't we move on to the next talk while I do that then?
Do you have a headphone around? Dr. Yasser? Do you have some headphone around?
Yes, if you'd like to move on to the next topic, I'll get some headphones. So
all right, so how about we move to the next speaker for the time, and we touch base again on it, if that's all right.
Yep.
Okay. So perhaps the next speaker will be Dr. Ali Hussein, Dr. Ali Hamadi. And perhaps I'll introduce Ali. There's no one knows Ali better than me. Although there'll be some bias in that. Ali is my college mate, so we studied together the primary medical school in Baghdad in Saddam College of Medicine. And most of our group left except Ali, who persisted and continued and finished all of his Arabic board in Iraq and was a consultant in spine surgery and orthopedic in the Medici of Baghdad. However, in one night that was very dark, Ali had to leave without prior preparations. So then Ali, we were so lucky to have him here in Australia. Ali completed his Australian fellowship, and then he did multiple spine fellowships in Adelaide, Melbourne, then Washington and Japan. So Ali now works in a spinal unit in Austin Hospital and Royal Melbourne as well. And so I would like Ali to introduce himself while we share your screen. Ali, if you can hear me.
Yeah, hi everyone. Could you hear me well?
That is once again an echo that is coming, but you have been clear when we started.
I think if you stop everyone on mute, if everyone is mute,
it's better now.
That is better now, Ali. That is better now. Do you mind to share your screen?
Will be much better if you everyone, even the speaker. I think will be much better.
Sure. I can mute myself. I'll mute myself now, but after you share your screen, just to make sure that everyone can see it.
Can you see the screen there?
You need to share the screen, Dr. Ali, with us.
I think we needed the unshare the last speaker.
Sure. Okay. Yeah.
Dr. Mohammed, can you do it from your end?
I can only allow people to share screen. So that is perhaps now I allowed everyone to share. So Ali, can you accept sharing?
Yeah, I think I hear okay. Your screen are sharing.
Okay.
I'll stop sharing and do it again.
Yeah, no worries.
Yeah, okay, so the previous talk, they should stop sharing. Then I'll share the screen.
All right. So, all right, I stopped sharing now, and all right.
Can you see it now?
I think Dr. Yasser Al-Khatib should stop sharing.
Yeah, I think you should stop sharing.
Do you mind, Yasser, to stop sharing?
I think Yasser on mute. I don't know whether he heard. Do you have a control there, Mohammed, to stop sharing from Yasser?
I ticked stop sharing, but I can still see him.
Yeah, because you shouldn't really see his slide.
Correct. Yeah. So, all right.
Alrighty, how are we going now? Any better?
Not really, Dr. Yes.
I'm sorry, I've got this speakers on, so I'm not sure what's going on.
No, it's better.
No, better, I think.
Is it better?
It's better if you have it.
Yeah, so do you mind to unshare your screen for Ali to...
Can you hear it?
Yes, sir. Do you mind to unshare your screen?
Yeah, I will start sharing now.
Sorry guys, I can't hear you now. I can't hear anything.
Can you see the screen now?
Yes, I can see that.
Yeah, okay. And could you hear me well?
Very well.
We can hear you very well. And maybe if we finish your presentation, then we move to you, Yasser, after that. And I apologize for the audience for this technology hiccup.
Yeah, thanks, Mohannet, for the presentation. So my name is Ali Hamadi. I'm a spine surgeon. As I said, we finished our training together, and I did the orthopedic training in Baghdad, in Medical City, Baghdad Medical City, and I became the director of orthopedic in 2004 till 2006. Then I came for a fellowship at the Alfred Hospital Spine Fellowship, and then I stayed at the Alfred since then. So I did a spine fellowship at the Alfred, and I did another spine fellowship at the Austin, before Austin Hospital. Before I go to the US, I did a complex spine surgery and deformity in St. Louis in Missouri, in Washington University. Then I come back. I still work at the Alfred as a spine. I do spine and trauma. At the same time, I still work at the Austin as a spine surgeon. And I do private practice in different places in Melbourne. So this is the just summary of the fellowship. My practice called Momentum Spine. And this is my affiliations. So today I've just talked about mainly my talk is about the aging spine, and also what is the current development in spine surgery. There's a lot of things change. So as you know, that the optimal spine is when you really 20s, and when from 20 to 30s, the more birthdays you have, the more problem will happen. So when you reach 30s, you start, if you get an MRI for anyone in 30 years old, they will see some degenerative changes in the spine. It might be asymptomatic, but still you will see the finding, which indicate that there is a degenerative process in the spine happening. And then once you hit 50s, the problem, you start having some facet joint because of the degeneration facet, the joint lost height, and the facet joint will become not really aligned well. And then as a result of this, you will start developing facet joint arthritis and collapse. So look, everyone will have this. If you're 50, every one of you guys will have this changes. But 90% of the people are the lucky people. They have a stable ankylosis. They have arthritis in the spine, which is stable, doesn't cause symptoms. While the unlucky one will start have unfavorable degeneration, what we call it. And the unfavorable degeneration will have a stenosis, central or foraminal, and then spondylolisthesis and deformities. And then the deformity and adult scoliosis is the extreme end of a spine problem. We'll talk about it. Ankylosis, you have degenerative changes, you have disc bulges, but you see both the foramen and the central, there is no stenosis. So the patient doesn't really have symptoms, occasional maybe back pain, but then as the things progress, you start having translation, you start to see here the foramen, you see this foramen is okay. But when you look at that, this foramen is really very narrow, and they start having foraminal stenosis. You could have this central stenosis facet quite big, and then a disc also bulge, and this will cause a problem and cause a stenosis. So then the clinical presentations are presented with low back pain. So it's like really just I hear it every time in my patient. So first they have some back pain, and after the back pain, they will start some have leg pain and radiculopathy. Initially, okay, manageable. Then they start interfere with their daily activities. And after, even with daily activities, you see the patient start not coping and start modifying their life around their spine. So start using, reducing their walking distance, use car instead of walking to the shopping center. They start using a stick, and later on, if this all fail, then they start having unsteadiness because of one, the problem they have in their spine. The second is deconditioning. And then you see when they start have postural changes due to muscle fatigue. So they tip forward and they use a frame. And if things get really worse and they have acute on a chronic problem, they may have bowel and bladder symptoms. So this is all you see here. The most efficient walking is the you see here the violet line. You can see the head over the center of the pelvis, and the pelvis center of the pelvis is over the center of the feet. When you walk, you don't need extra muscle to work to maintain your posture. This is the most efficient type of walking. Once you start bending forward, then you will start compensating a bit with the muscle. When you use to the we call it orange, then you start using the muscle of the back to try to straighten while you walk. And if you go further forward, then you have this, what they call it, fatigue pain. When it becomes evening, they start having a problem because those muscles were working all the day to try to maintain the head over the pelvis. And then where they have fatigue pain. And you can see here, this is the optimal one, while here they just step forward, and here A is where significant posture change. When you examine them, you see the forward posture, they have a stiffness in the spine, a sensation here and there, and they have some reduced power and weakness. Plain films, really no one uses plain film nowadays. It could show some degenerative changes, but it really doesn't really initiate any management. It's difficult to interpret. X-ray of the pelvis is very important because I've seen a lot of people the same way. They may have hip surgery or shoulder surgery, and then they come presented with the same thing as Munjid alluded to earlier. Or the other one around, like we do spine surgery, then unfortunately the patient sit next to you and said, "Oh, look, thank you very much for the operation, but really I still have the pain." So this needed really to be sorted prior to the operation. So CT scan is good to show you degenerative changes, show you slip, it show you the bony landmark, so you plan your surgery, but it doesn't really show you well the changes happening at the disc and also the nerves. And you hear the MRI. MRI is the standard. All my patients have CT and MRI before surgery if they needed to. And you see here, you see the disc, this is above, this is a normal disc. You see here black at the back, black at the front, gray in the middle, and there is a bit of gray line in the center. This is a normal disc. You see, as you go down, this is what happened. The disc become black, and this means degeneration process, and they start to have bulges. And you see here just a small bulge, and then here further and nerve rotation, rotate the nerve root. So now I just wanted to talk about what changed in the spine. Look, the spine nowadays, we approach it from different approaches. Too many approaches. So there's posterior. The posterior approach is the key and the standard. Most of the things we can do it now from the back. However, there is other approaches, anterior. I used to do a lot of anterior approaches, but nowadays with the ability to do a lot of things from the back, I really significantly reduce. The only indication for me to go up front is sometimes debridement of infection and sometimes burst fracture when you have to decompress anteriorly. So this is just one case. I show you how this is an anterior approach. This is a patient come to the Alfred Hospital, 28-year-old, sustained, he's a passenger high-speed MBA, and he had some injury which sustained a burst fracture, but he was very lucky. He had biologically intact, only some thigh paresthesia, but had a significant injury. This is his initial CT scan. You can see here, this is a burst fracture, and you see the significant retropulsion here, causing significant pressure on the core, on the dura. And if you see here, it's very hard. You go from the back, decompress this one completely. Like this fragment, you have to remove it. And also the posture of the spine or alignment, you have to change it. So in this one, I normally go front, so put the patient in lateral position, and then after that I do oblique approach, expose the spine. This is the spine, this is the psoas muscle. I put the stitch in the psoas and remove it from the, and you can see here, this is the fracture of the patient. So I remove all the piece of bone at the front, which is here, to approach the one at the back and to make sure that I see the nerve, I see the dura, and everything can protect it. So you have to have a good access. The aorta will be just at the front here, and I retract it forward. And this you see here after you debrided all the bone, and then I put some cage, which is that one, and I use a rod over the cage, put rib graft. We take it during the approach and put it just to ensure healing, the fusion later on. And you see here at the end, I put a plate. You see here, this is the position you obtain. There is a cage, maintain the alignment, and there is a plate. Then I flip the patient and do a posterior approach after after I did the decompression and stabilization from the front. So if you look, this is the CT scan after the operation, the same patient. You see the bony fragment completely removed, the cage maintained the alignment of the spine, and you see here I put a lot of bone to ensure fusion. So this is one of the few cases which you really have to do anterior approach. Posterior approach is a standard for us, and we do it most of our spine. It's used for a disc. So this is one of cases you will see. This is a young patient, 3-month history of acute back pain and S1 radiculopathy. So you can see here there is a disc bulge. But look, most of these bulges, they resolve with time. Look, a problem is it depends on the patient, because what will happen, most of the patient, they're not really, if you tell this patient that in 6 months, 9 months, I could assure you that this patient will get better if you leave him without surgery. But then the problem, patient can't wait. Most of them, they don't wait. You ask them for injection, you send them away, they come to you after three days, they send a lot of email to my office saying, like, I can't really sit in the car, I can't walk, I can't. Sometimes nowadays very difficult to keep someone 6 months out or like out of work. So anyway, my approach to this one when I see them is injection. I could assure you there is no patient ever in my room have an operation without injection, ever. Like I don't have any single patient in a private. In hospital, when they come with a trauma, they will have some of them trauma different, but the degenerative spine, I always inject. So you do a nerve root injection. Most of them, they recover well, but unfortunately, they sometimes recur. And then if you recur, I do discectomy. And when I do discectomy, the problem is you heard about it is wrong level surgery. Look, the problem with the discectomy, you have to have experience with those ones. So when I do discectomy, for example, I use a microscope, I use a small incision about 2 centimeters. But at the end, I save this picture. This picture shows the patient that I'm the right level. I put something in the disc. I decompress above this, indicate the level below, and this is the level above. So I did decompression and I'm in the right disc. And even the disc which I remove, I send it to histopathology. And my fellows, they keep saying, oh, why are we sending to histopathology? Because the problem is sometimes patients come to you saying, oh, I still have disc. Can you do an MRI? And you know the recurrence is about 20%. You do MRI, you see a disc. And then when you see a disc, the patient, especially work cover, a lot of litigation, they say, look, you didn't remove the disc. Actually, in fact, no, I did remove the disc because I have a histopathology showing there is a disc material 2 centimeters by 4 centimeters has been removed from you, and I am in the right spot. So this is a recurrence. This is what I routinely do. And here I just use microscope all the time. Look, definitely my microscope make me see better. I see the nerve very well. I remove it to the side. It's safer for me to do it this way. So then you see those patients, they come, a lot of people with a stenosis, like this old people, this different. They have central, they have more of a central stenosis, facet joint arthritis, and neurologic claudication. For those patients is a different group. So in this one, I also do injection, but here, the type of injection I give is epidural because it's central, it's usually have bilateral leg. So this one is not a nerve root, it's more of epidural injection. And usually most of the elderly people, they are a bit more tolerant, and they really, sometimes you go away with just injection to those patients. And you see them after 6 months, you can repeat injection if you want, and then see how they goes after that. I see this again. I did a second injection for this patient after a few months. And look, I mean, seeing the patient in your room multiple times is very important, because what will happen, you come to know the patient, you know the characters of him, you know he's not like really a complainer, so you know him and he know you, and then when you do the operation, you make sure you operate on the right one. So now what about the navigation or robotics? So navigation, at the Austin Hospital, I use the arm, which is this machine. So the patient, every single patient, private Austin, I use arm. So the patient go to sleep, and then we put a marker. I put a marker here on the spine. I expose the spine. I put a marker, and this the arm come over the patient, do a CT scan while the patient in prone position, and then I will navigate my screws. So here you see this is Reese, one of my fellow. He's a neurosurgeon. And you see here, this is the navigation we see here, and this is what we see in the screen, and we navigate screws. navigation, I mean, a freehand technique of insertion of screws is proven by in the literature that it have about 74% accuracy. So even if you put 10 screws, 3 could be in the wrong spot, which is, I don't think is good enough. While navigation, when you navigate, is about 99% accuracy. So, and it's available, why we don't use it. Okay, anyone could do it. You see the screw here, you navigate it, you put the screws in the right spot. No margin of error is very low. And this is the other one. You see, I put SI screws. I put it from S2 down to the pelvis, and you can see how easy to put the screws across. And you see it in 3D. And you see here, this is the end of your screw will be. You know that you are not out of the bone. So it's quite accurate. I did around more than 100, and I did all of them, all those patients. I did a post-op CT, and I find it's very accurate to prove the accuracy of this technique. And then there is a new technique, which I use it now at the Alfred, they call the 7D. And this 7D is, this one doesn't need navigation. So you do a CT of the patient pre-op. The only problem when you do the CT in the patient pre-op is that when you position the patient in a prone position for operation, the spine changes its position. So it flex or extend a bit more, and this make everything wrong. So what we use a facial recognition camera, which has a 3D facial recognition. So this, when you put the spine exposed, it recognizes the anatomy from the CT and adjust your screw placement to the current position that the patient has. And it's really a good technique. So this is what you see. You get a camera which map the area where you want to the screw, and then you place the screws. Like, see how nicely you could put the screws with that one accurately. And this is now, I think in a few years, if you don't navigate and you have a problem screw placement, you will medical legally have a problem. This is the other one. Also see that one have a disc central and causing compression in the nerve here. Tried injection. I think this one referred to neurosurgeon. They did first discectomy for him, and then you see here he have a recurrence after discectomy, and then twice he have discectomy with the neurosurgery. So I did a fusion. So just you see the screws placement, and then you put cage, because at this stage when they recurrence twice, mean even if you remove it, it will recur. And I just show you this one is an interesting case. Actually, I did at the Austin Hospital. So this patient referred to us from St. Vincent Hospital, which is a tumor center. With this patient, he's a 60-year-old with this mass. You see the C2 is a quite big mass over the C2. And actually his main presentation to us is difficulty in swallowing. He presented to hospital not because of anything, it's just difficulty in swallowing and some headache and pain in the neck. So when we saw that one, we planned to do the operation for him. We don't know what pathology we deal with, so the St. Vincent staged him and sent him to us. So this you see the MRI, see this quite big mass causing pressure spinal cord, and he become really myelopathic down in the leg. So what I did, I removed this tumor completely from the back, took biopsy, and then I fused it to skull to C5 and put bone graft. Because if you don't put bone graft, any metal, you could put whatever, but any metal we know in orthopedic, any metal you expose it to million cycle of loading will break. And so I hope that bone graft you see here will end up with a fusion. So otherwise this will break us at the stage. So I did this one, and you see they really, I mean, it's unusual because the histopathology come as osteogenic sarcoma. And you see here after radiotherapy, so the same patient after radiation of the tumor and you remove it is significantly improved. And he have a good reasonable survival. It's a similar case, stenosis, we just do fusion. And this is the higher end of spine. Look, I must say those one is a problem. People come to you, they relatively 65 to 75 with this deformity, significant deformity of the spine, a lot of degeneration. You see the main problem with this one, the chest impingement on the pelvis, and really they have severe pain. They can't walk, and usually they're good people, but the problem is operating in this people, they have about 70% in the literature, 70% complication rate. And this could be from smaller dural tear to to a high complication road break and pseudoarthrosis and things. So I operate at the Austin in those one. Operate about 3 to. I don't operate on those one in private at all. So when they come to me, I send them, even if they're privately insured, I send them to the Austin. I need a big team, ICU. I have 2 fellows there at the Austin, so I could use those to help me in the surgery. I have all what I need. See this one, you look here, you did the parameters that we measure to correct the deformity. And then you see here, I always try to do whether how much corrigible. So I push on the spine to try to straighten it. They come with, you see, with this impingement, and they normally they nice people. They say, look, I can't really walk, and normally what I do, I put them in a brace, because I tell them after the operation you will have a significant stiffness of the spine. So I put them in a brace to trial them and see whether they tolerate the brace. If they can't tolerate the brace, then they will not like the operation. So then the ultimate, as I said, they will be like a 3 months or 6 months. Every 6 months I do one of those. Sure. And this is what you do. It's a big operation. You put the patient prone position. You have a neuro monitoring, traction on the skull, just to give you a bit of correction. And then it's a big incision and do osteotomy to correct the spine. You see, this is the shape of the spine after the operation. This is the shape of her after the operation. This is X-ray taken in theater. You correct them significantly after you do osteotomy of the spine, and then but they end up with a stiff spine. And you see here, what about disc replacement? This is the last things. People talk about disc replacement. The problem with the disc replacement on the lumbar spine is the natural history. When you have arthritis in the spine, the body tries to fuse, and that's why you have ankylosis and degeneration. But then the problem is with disc replacement, you try to keep them moving. Most of those patients have already facet joint osteoarthritis, and moving this doesn't help with the pain. So I use disc replacement in the lumbar spine. I use them in the cervical spine for special cases when they have multi-level and I don't want to fuse too much. I'll use it. But as I said, the problem is the natural history of the spine. When you have you try to enclose and you're pushing against the natural history, and when you try to work against the natural history, what the result will be. And if for example this fail and the patient still will have pain, then it's very difficult to salvage, because what will happen, you have to remove this one through anterior approach. And and Mohammed know very well, going through scar again, the abdomen retroperitoneal, to try to take that one again with the aorta and all the blood vessel around is not really something easily you could do. So the salvage is also not good. This is in the cervical spine. I use them, as I said, because the different approach is easy to them if you want to salvage them, and it's a good operation really in the cervical spine. And that's all.
Thanks. Thank you, Doctor. Thanks.
Thanks, everyone. Did we take the question now, Mohammed, or?
No, later on, Doctor. I think the arrangement in these webinars, we take them later on.
Yeah,
no problem.
Right in the end. So I think I will. Thank you so much, Dr. Ali. That was fantastic. Third speaker, actually, back to Dr. Yasser. Are we? I can see your message saying that you might have not resolved the issue, Dr. Yasser.
No, I think last time when Dr. Yasser came in, the sound was okay.
Okay.
To some extent. Why don't you
hear us, Dr. Yasser?
Can you hear me? I can hear you clearly. Can you hear me, guys?
Yeah.
Keep on going, Dr. Yasser. See how we go.
I don't want to disturb everyone with a weird echo. I apologize about that. Are you still getting an echo on your end?
Unfortunately, I do get a significant echo, Yasser.
Why don't you go ahead? Go ahead. I think we all right.
Okay. Dr. Ali, can you please and share your screen? So see,
I already did, Mohammed.
Okay. Lovely, thank you.
Right, can you see that?
Okay. We can see your screen. Well, let's see how we go, just because it doesn't have any other option. See if we can continue like that, yeah.
Apologies about the bad audio. I guess we'll just have to make do, and you tell me when you've had enough, and I'll of the echo, and I'll stop talking. Might just make it a little bit quicker than anticipated in the interest of everyone. My hip and knee surgeon in Sydney, in the Nepean region. I've done some fellowship training in terms of arthroplasty surgery. I wanted to follow on from Munjid's points about talking about mainly arthritis, this time of the knee joint. I wanted to touch base on who's the type of population that benefits from a knee replacement. What are the common questions that we get asked, and what are the up-to-date advancements in terms of overall surgery, including anesthesia and some technological advancements. First, I wanted to say that we're talking here about a total knee replacement, which involves replacing the articular surfaces of both the tibia and the femur, which is this screen on the left, rather than a partial knee replacement, which replaces one component of the knee. So who's it indicated for? Well, first of all, it's indicated for patients who have unremitting pain, at least moderate to severe pain, so 4 out of 10 on a pain scale, and a persistent pain that has occurred for a long period of time. They usually have to have documented knee arthritis, most commonly that is with osteoarthritis, but of course it can be other types of arthritis such as inflammatory arthritis or crystal arthropathy, most commonly gout. You have to have a suitable patient, and you have to have disease symptoms that are not relieved by other measures, such as analgesics and non-steroidal anti-inflammatories or opioids, as touched on before. Other modalities include injections, whether it's corticosteroids or hyaluronic acids, or even other lesser surgeries such as knee arthroscopy or joint-preserving surgeries like osteotomies. Again, this is the Bible of arthroplasty surgery. We can see that in 2019 there were nearly 60,000 knee replacements, and every year it seems to be going up by about 1 to 2%. Most of them are total knee replacements rather than partial. And this is a fairly common graph that comes up in terms of the population that has knee replacements. So we can see that most of them are patients between 65 to about 75. And we have a constant small group on either sides of that age spectrum. And most of them seem to be females, so it's more common in females, probably because they're more likely to be sensible and present when they have persistent pain. The increase in knee replacement surgery, we're not seeing a corresponding increase in failure of these knees, so they are actually doing much better than before. We can see on this graph that the older generation of knee replacements had slightly higher revision rates, but as the newer generation come along every point in time, there is a much lower revision rate. This is our current generation of knee replacements from 2013 onwards, and we can see that with the modern prosthesis, there are far less revision rates compared to previous generation, mainly because of technological advancements. Unfortunately, the main reasons for revision remain infection and loosening. So a common question that we get asked is, am I too young to have a knee replacement? Well, not necessarily. However, we do recognize that in the younger population, the chance of revision or requirement for revision along every point in time after surgery is slightly higher than other groups. That may be because of different functional demands or different expectations from the surgery or what the prosthesis can provide. The other question is about obesity. And obesity is a problem because if there is significant obesity, which we can see here in the purple line, where the BMI is more than 40, so significantly obese, we can see that the complication rates are higher. But keeping that in perspective, for example, at 4 years, the revision rate is 3% compared to about 2% in an otherwise healthy patient with normal weight. So it's not astronomically higher than others. Bariatric surgery has helped in not only weight loss, it has helped in patients experiencing lesser or a lower rate of complications after surgery, such as infection or other technical problems. So just as an update about where knee replacement surgery is today, a lot of improvements have happened. This starts from the type of anesthesia we use, which is now mostly under spinal anesthesia and local nerve blocks, and also infiltration of the joint with local anesthetic, which helps with recovery, patient recovery afterwards, and perception of pain. We do use low-dose dexamethasone steroids to help with recovery as well, and we use a reasonably cheap drug called tranexamic acid, which helps with decreasing blood loss after surgery and has significantly decreased the rate of transfusions for a drug that is otherwise quite safe to use and pretty cheap and readily available. Evidence is pretty conclusive on tranexamic acids and its safety for use in joint replacement, whether it's hip and knee replacements, and they tend to be commonly used in arthroplasty centers. In terms of instrument development, we've gone a long way from the old instrument that involved insertion of a jig in the femoral canal, and now we also know that we can't use that type of jig all the time because we do have deformities sometimes that we can use these old instruments in. So we've moved on to development of other equipment such as computer navigation, 3D custom printed jigs, or even more recently robotic surgery. The benefit with computer navigation is that it was giving us a high degree of accuracy in terms of insertion of components, and it was allowing us to plan and execute the surgery to exactly where we wanted it to be. But of course, with all these technology, there is an increased dependency on the computer. So if we don't enter the necessary landmarks inappropriately, then there is a chance of error. And of course, it is more expensive. It's particularly useful in cases like what I showed before, where there is an extra-articular deformity because the computer is pretty clever at calculating where the joint components need to be. And there are studies that have shown that computer navigation has been associated with better range of motion and a better patient satisfaction after surgery, and it may actually reduce the revision rate in the registry. But it does add about 17 to 20 minutes to the duration of the operation, and it does come with a cost increase. It does also involve us inserting trackers into the joint, and therefore there is a slightly higher increase of fracture risk. There is, of course, 3D printed models, which is reasonably, modern technology, where an MRI or a CT scan is performed preoperatively, and the patient has a custom-made cutting block fashioned, sterilized, and then used at the time of surgery. So there is a bit of a compromise between computer navigation and conventional total knee replacement. It doesn't use that live computer feedback, but it does give us the ability to put away the old jigs, and it does allow for planning to occur in the clinic outside of surgery, so it does tend to be a little bit quicker. And this is the type of planning that we get to. Red spots, for example, over here show us where the cartilage is significantly worn. We can see the deformity before surgery, and we can plan our surgery appropriately. We know what kind of components we use and what the landmarks that we will, look for at the time of surgery. So that's how it looks like at the time of surgery, where the model is inserted onto the femur or the tibia, and surgery executed from there. And also used to use some pressure monitors that help with joint balance. For example, if there is a problem with joint balance, we can see here that the weight is not distributed evenly between the two sides of the joint, whereas we want to be looking at something like this where the weight is distributed evenly. And that has shown a better function in terms of patient outcomes afterwards. I guess this is where we are now with robotic assisted surgery, where we have a robotic arm that is a mix between computer navigation and a slightly newer generation of robots. And robots themselves are not particularly a new instrument in surgery. They have been used in other fields of surgery for many years, but have recently come into the orthopedic field. They are obviously very clever and can execute the plan to a high degree of accuracy. The problem is more to do with their costs, and there is still an issue with fracture risk and restriction to only the big companies that make these robots, but in time this will become more popular. I do have a bit of a video here to share. I'm not sure if it will play, but I'll give it a go. You can see here where the robot starts, and this is registration that happens at the time of surgery, where you can here play with the plan depending on what you want to achieve good joint balance. And from there on, once you've got everything inputted, you know what your plan is, the robotic arm can come in and assist with the placement of where we want to provide the cuts. So here we can see it coming in. I can help it along. It's secured to the patient's bone. In this case, it's the femur, but we do the same thing on the tibia. Once it's secured, then the joint is cut to allow insertion of the components. We can validate that at the time of the procedure, and if we're happy with our landmarks and ready to go, then it gets pulled away. We do the same thing on the other side, and then in go the components. Once we're happy with the trial components, the real components go in, and so on and so forth. And that becomes the new knee. Fortunately, this technology is only available with certain companies, but in time, I think it will be fairly mainstay kind of surgery. Okay. So just moving on to the next slide. Also, suture closure techniques have helped. We've got new ways of soft tissue management, which is also helping, like this barb suture, which tends to improve wound healing, stops pinching at the knee, and therefore makes wound recovery much better afterwards. All these things allow early ambulation of the patient, early mobilization, and better recovery. Physiotherapy has also changed. Mostly we have moved from a hospital-based physiotherapy program to physiotherapy in the home. Health funds have now got on board and tend to send patients home with physiotherapies to visit them in their own home so that they can rehabilitate there, allowing an earlier recovery and an earlier return to their normal home environment. And most of the health programs now have a similar. Sorry about the echo again. Sorry about the technical difficulties, and thank you very much for your attention. I'll unshare it.
Thank you very much.
Thanks, Dr. Yasser. Well, may I suggest, Dr. Yasser, if we can do a separate recording to your lecture, which was an excellent lecture, just to add it to the rest of the recording, because most of the time the sound was not clear. Yep.
I agree with that, and then we can sort of add it to our YouTube version for later. Yeah. All right. So for the sake of the time, I would like to invite our last speaker, but not the least, Dr. Mustafa Taher, to cover the ankle and the foot update, and then perhaps after that we open the panel for all questions for 4 speakers. Dr. Mustafa, can you hear me? We can see your screen. Excellent.
Can you hear me?
I can hear you very well. Yeah, go ahead, Mustafa.
Perfect. Thank you. Thanks for the opportunity to talk about ankle arthritis and advances in treatment. Just briefly, a little bit about myself. So I did my medical school at UNSW in Sydney, and then went through the Southside training scheme in New South Wales. I did a few fellowships, one being with Munjid locally a couple of years ago, and then I went overseas to Switzerland to do another overseas fellowship, as well as another local fellowship. So primarily doing foot and ankle surgery, but also limb reconstruction as part of the limb reconstruction unit at Macquarie University Hospital. I'll get into it. So a little bit about ankle arthritis. Unlike hip and knee arthritis, ankle arthritis is often secondary to, or the vast majority of it is secondary to trauma. Hence, it tends to present in a younger patient population, so a little bit more rapidly progressive, and it is a little bit difficult to treat. There's a mechanism of developing ankle arthritis tends to be either from direct cartilage injury or chronic ankle instability over time leading to arthritis. Often untreated ankle sprains is probably the most common cause. Patients with chronic lateral ligament instability end up with varus tilt and medial sided ankle arthritis. As you can see, in terms of anatomy, there are medial and lateral stabilizing structures. Once you have a sprain, you end up rupturing those, and if they don't heal adequately, which they can heal adequately, and some patients end up having a stable ankle despite having injury, but if they don't heal adequately and they end up with chronic instability, that can lead to arthritis over time. If you look at the knee versus ankle cartilage, in the ankle there is higher congruity, so it is less reliant on supporting soft tissues. But if you do get instability, the shear forces can cause some significant damage to the cartilage. But the difference though is the ankle cartilage is half the thickness of knee cartilage. It is higher density and higher compressive modulus, but so it takes a fair bit more stress to wear it out. But unfortunately, it's not. So once you get damage to it, it's not resilient enough. Now you can see there's quite a number of causes for arthritis. The most common is joint injuries. So chronic problems with chronic loading abnormally often leads to the arthritis. So you can either have acute ankle damage from an ankle sprain, or you can have problems with chronic malalignment, which can either be due to people with chronic flat foot deformities or chronic cava varus deformities if they've got Charcot-Marie tooth, or if they've got trauma and deformity above the ankle joint at a level that can cause some alterations in the forces that go through the ankle joint, and over time it can cause some problems with arthritis. But as the most common cause is usually direct damage to the joint. Ankle fractures are very common, and we don't routinely use an arthroscope on patients who present with ankle fractures, but if we did, you'd identify quite a lot of cartilage lesions in acute ankle fractures, and over time that unfortunately starts this cascade of developing post-traumatic arthritis. So the number of injury patterns, patients can have dislocations, impaction injuries, fractures, ligament injuries, and then intra-articular fractures, which are significantly more
damaging to the joints, so if the tibial plafond or talar fractures. And then, as I mentioned, higher up, if you get a tibial fracture, that can cause some malalignment as well. Malalignment over time leads to the abnormal shearing forces and eventually arthritis. So risk factors, as I mentioned, having a sprain, you can then end up with an osteochondral lesion from the sprain. And then over time, that leads to post-traumatic arthritis. If you get the sprain, it causes deformity. The deformity then leads to a vicious cycle of increasing wear and then increasing deformity, increasing wear, and eventually that leads to rigid deformities and arthritic changes in one compartment. As you can see, there's an example of a case where a patient had an ankle fracture treated. Unfortunately, over a very short period of time, within 2 years, the patients ended up with quite advanced arthritic changes. This is a graph showing how ankle fractures cause the most damage. So in terms of progression to arthritis, patients who've got ankle fractures drop off very quickly into the end stage arthritis pattern, whereas patients who've got recurrent ankle sprains have a more gradual decline. One severe ankle sprain tends to cause some serious damage. So if they get an intra-articular osteochondral fracture, that can lead to progression, more rapid progression to arthritis. So there's a whole bunch of things that come into how ankle sprains can sort of pan out in the end. There's patient factors, environmental factors, and also the treatment modalities from physiotherapy, splinting point of view. And patients can either end up from chronic ankle instability, where they get recurrent ankle sprains, or they can cope and fully recover and end up with no problems. So the risk factors for arthritis, we said either trauma or ligament injury, and then over time, that leads to the arthritic changes. Symptom-wise, they get pain, swelling, stiffness, and then they get problems over time with decreasing range of motion, pain with range of motion, and the like, and they have instability on clinical examination. So you can do an anterior drawer on the medial and the lateral side, and you can feel laxity both of the medial ligament and the lateral ligament. The talar tilt test checks the subtalar joint in addition to the ankle joint. It's really important to look at, so our approach at the Limb Reconstruction Center is we look at alignment in the entire limb. So it's important not to miss femoral, knee, tibial, and also hindfoot, midfoot, forefoot malalignment. They can increase stresses on the ankle joint over time. So it's important to get weight-bearing x-rays, and we supplement that with additional scans if we need to. In terms of deformity assessment, I like doing a hindfoot alignment view, or a Saltzman view, which gives me a really good idea as to whether the patient's varus or valgus. It can be a little bit deceptive visually looking at that, especially if they've got multi-level deformities. And then we can look at a whole bunch of other radiographic factors, whether they have talar tilt or a subluxation, the Meary's angle, which is the angle, how cavus, how high an arch or flattened an arch patients have, and also looking at how to correct all the deformities around the ankle arthritis, because it's the key to correcting or preserving joints in general anywhere around the body is neutralizing the forces that go through them. And especially in the foot and ankle, due to the vast number of joints that are present, you need to look at all the deformities present and look at how you can either non-operatively or surgically neutralize the forces on the big joints, the subtalar joint, the ankle joint, the talonavicular joint, to try and minimize progression to arthritis. So there are classification systems. So you can have isolated ankle arthritis, you can have arthritis with deformity, or you can have arthritis with deformity above and below the ankle, and you can have arthritis in the ankle and arthritis in all the other foot joints. Now, this is an example of a patient who clearly has had quite a severe injury to the ankle, an osteochondral defect, and that is one of the biggest risk factors to developing post-traumatic arthritis. MRIs can be very useful in this case. Why is it important to diagnose problems with the ankle early? As I mentioned, unlike other degenerative arthritic changes, the ankle has a traumatic starting point. And if you can address the instability early, you can prevent progression. If you can address neutralize the forces on the ankle joint early, you can prevent progression. Now, this shows that a lot of, for example, in NFL players, the patients who've had ankle injuries tend to progress to getting ankle arthritis over time. And then this is looking at adolescent athletes who've had injuries, chronic ankle instability, and they've looked at how they're functionally, they tend to have some problems, and that's early in life. So if we can prevent that from progressing by stabilizing their ankle joint, it prevents the progression to post-traumatic arthritis. And this is an example of a study where they looked at MRI mapping normal and abnormal cartilage, and patients who've had injuries actually, even though they might appear to have normal cartilage on a normal scan, the quantitative T2 mapping shows some significant changes over time if they've got ankle instability. So how do we avoid arthritis? Stabilizing the ankle joint in young patients. There's been advances in the way we stabilize the ankle joint, so we can now do it arthroscopically. We don't need to do any big open incision, so you get less scarring, less damage to the proprioceptive tissue, you get faster recovery, easier to revise because you're not doing any major implant removal as part of your revision, and it's very anatomically safe. So this is an example where there's suture anchors and you pass them through the lateral ligament structures. You can do that on the medial side as well, and you can supplement it with the inferior extensor retinaculum. Now, patients who've had arthritis and chronic ankle instability have also shown to improve by just stabilizing their ankle joint. So just because someone has some signs of arthritis doesn't mean they can't have a stabilization, because it may actually improve their symptoms. Now, in terms of non-operative measures, we all know it's similar to treating other joints, but sometimes you can use orthotics if they've got varus deformities without advanced arthritis, and you can offload the affected compartment. Using boots can help, but patients are not generally very compliant. You can use injections as either diagnostic or therapeutic measures. Unfortunately, once patients get to the end stage, they usually need surgery. Now, we can do salvage surgery. So if you get a young patient, really it's very difficult to offer a young patient a fusion or an ankle replacement because of the longevity issues with both. So it's a good idea to look at alignment, and there are numerous studies published that show correcting alignment and deformity definitely makes a difference to pain symptoms and functional profile. So joint salvage surgery, if someone has medial arthritis, you valgize them. If they've got lateral arthritis, you varize them. You can do supramalleolar or inframalleolar deformity correction, depending on whether it's tibial or talar-sided. And then in addition, adding the stabilization part. And that combination can preserve the ankle joint for a little bit longer and delay the need for more advanced surgery. This is a case actually of a patient who presented to me who had surgery in a trauma hospital. The patient unfortunately ended up with a short fibula. The medial ligament was attenuated. Their syndesmosis was not reduced adequately, and they also had a severe plantar valgus deformity underneath their ankle joint, and you can see there's valgus arthritis. So it's hard to, the traditional technique to fixing this was to fuse the ankle joints. I don't like fusions. I don't fuse ankle joints. The aim is not to fuse them ever unless it's absolutely the last resort and there's no other options. So in this case, did this, and that's his deformity corrected, and you can see he's had a varizing osteotomy of his distal tibia, a fibular lengthening osteotomy, a deltoid allograft double bundle reconstruction, as well as a flat foot reconstruction, so lateral column lengthening, cotton osteotomy, and a heel shift. Correcting, neutralizing all the forces, you can see the talus now sits in a neutral position under the tibial plafond, and that avoids the need to progress to ankle fusion or joint replacement surgery. And this patient still has very little symptoms from his ankle joint, so we're not going to progress to a more advanced treatment. Arthrodesis surgery, traditionally the go-to treatment for ankle arthritis. It provides good pain relief, but it causes loss of motion. It causes an abnormal gait. It's guaranteed to progress to adjacent joint degeneration. There's numerous studies that show the subtalar joint, the talnavicular joint, the CC joint, all the midfoot joints, they pack it in within 10 to 15 years, sometimes less. And patients are not happy with ankle fusions. So we've got ankle replacements as an option. Traditionally, they've had poor results, but more recently with the advances in ankle replacement or generally arthroplasty technology, we're now getting some excellent results in patient-reported outcomes. And many international foot and ankle societies now recommend it as the preferred choice of treatment for end-stage ankle arthritis. In comparison, it maintains movement and it provides better gait, better function, less pain, and patients often have better quality of life. One of the major advances is the fact that we can have patient-specific instrumentation. So similar to what was presented earlier by Munjid and Yasser, we can make custom 3D printed osteotomy guides, and those can give us an accurate, reproducible, and decrease the surgical time and correcting deformities without guessing. And that way you can give patients very neutralized ankle replacements. The other caveat to that is you have to neutralize all the forces around the ankle replacement. So we do calcaneal osteotomies, lateral column lengthenings, or midfoot osteotomies to decrease a high arch, or tendon transfers. You have to balance everything. You can't just bang an ankle replacement in and walk away and think that it's all done. If a patient has deformities elsewhere, they have to be corrected. Otherwise, the ankle replacement will fail. This is an example of a case. So that's the PSI guides that are printed. You can see that we use them. We pop them onto the tibia. We use X-ray to confirm that they're accurately placed, and then you can give a patient a very reproducible ankle replacement. So they allow the accurate correction of the intra-articular deformities, and then you have to combine that with correction of all the extra-articular deformities to get the good results. This is an example of a patient who had severe valgus arthritis. You can see that's been neutralized, and there's also a heel shift performed underneath that to try and neutralize the forces and make sure the deformity is corrected. Now, the good thing is now with advances in implants, we've also got, for difficult total ankle replacements, if you've got deformity or bone loss or revision surgery, we now have implants that are getting close to what hip and knee replacement implants are providing in terms of restoration of bone stock or metal for bone. And you can see this is a stem tibia, which allows a more stable construct in cases where you don't have enough bone. There's an example of one of Munjid's patients. Actually, this patient had an ankle replacement under another surgeon in Sydney. Unfortunately, it did not work. That's one of the resurfacing type ankle replacement. So she presented to Munjid, had a revision, and this is an example of a stem prosthesis that can be provided to this patient, which gives them a much more reproducible result. Traditionally, if that ankle replacement had failed, we would have gone to doing a tibia talar fusion or a tibia calcaneal fusion, depending on how bad the problem is. Patients had terrible results. They get short legs. They had potential for non-union. and the amputation rates were not insignificant. So having these advances in the cascade of what we can provide them with implants has definitely made the ankle replacements much more safer and easier to offer to patients with all kinds of deformities. So you can see we've gone from, now you've got the option of fairly basic implants all the way to revision implants that require much stringent, stronger fixation to the bone. This is a case that was treated at Macquarie University Hospital. You can see the preoperative planning. So I've got the privilege of actually working with Munjid and his engineers in the company, Osseointegration International. We can offer our patients some novel implants and novel treatments that are not available or not offered by anybody else. So this is a case of a gentleman who had a talar avascular necrosis, presented with a problem where he was offered a tibiocalcaneal fusion. The results are terrible. The union rates are low. He wasn't happy, and he came from Tasmania to get an opinion from us. So this is something that we designed. So Munjid and I designed this implant specifically for the patient, and then we 3D printed it. So you can see this is this patient's X-rays. You can see the talus has subsided because of avascular necrosis, and he's lost height. The implant's not stable. So he had a first stage revision where we debrided all the necrotic remaining talar bone, which had not dissolved but was not useful to keep. And unfortunately, his talonavicular joint was also involved, essentially, or gone. So we put an antibiotic cement spacer to make sure this was not infection related. And then we designed this, and you can see the 3D modeling, the CAD modeling, the implant that's printed with a mesh Voronoi lattice mesh porous coated surface, and a 3D model of the leg that we used for templating. And then this is his X-ray. So you can see the implants being put in. He's got very strong fixation on all sides. He's actually fused on the talonavicular and the calcaneal side, and he is mobile. We saw him at the 6-month mark just 2 weeks ago, and he's doing extremely well, very happy and satisfied. This traditionally as I mentioned, would not have a lower, an insignificant amputation rate. And so we've managed to salvage that for him. The other thing is we've got options for taking down arthrodesis. So patients who've had ankle fusions, who've got ongoing issues, their gait is abnormal, they're unhappy, they've had ankle fusions in a bad spot, so they're equinus, or there's varus residual deformity, and they want to have a mobile joint, or their subtalar joints packed it in and they need a fusion there. We can actually go and take down the arthrodesis and give them an ankle replacement and make it mobile again. It is difficult surgery, has higher risks, but now with the 3D printed osteotomy guides, we can make that much more accurate, reproducible, and it's safer. So this is an example of a patient who had, you can see the plate anteriorly.
Dr. Mustafa, can we try to summarize, as perhaps we need to leave some time for the questions, if you don't mind?
No problem. Just one more thing. So this is a 47-year-old ballet instructor. You can see end-stage arthritis. She still does ballet. This is 3-month follow-up. You can see the ankle replacement, and that's the ankle. She's on point with an ankle replacement. So it provides excellent range of motion. It's a take-home message. You can see the video. There's an ankle replacement, maintains movement, good alternative to ankle fusion. Patients love the pain relief and the preservation. And we've got some advances in technology that provide patients with much better options with the ankle replacements. Thank you.
Thanks.
Thank you very much. Thank you very much, everyone. Actually, we feel privileged to have excellent presentation to cover a huge topic. I felt that I learned a lot. I'll start. I have one question to one of the speakers, maybe mainly to Professor Munjid Mudarris. It's interestingly, I saw one of the physiotherapists who said that nowadays a good percentage of his cohort patients are medical students coming to him with back pain, shoulder pain, etc. The question that some of the audience asks, what is it that we're doing wrong, Professor Munjid? Is it us? Is it the posture? Is it the lifestyle? Is there any advice as a preventative not to go for this pathway of needing to touch a joint or replace it, etc.?
Well, yeah, that's a very good question. Actually, our lifestyle is changing. We spend long hours sitting in a car. We spend long hours sitting in front of a computer. As you can see, I'm stooping, and with our sedentary work, this lead to contractures of ligaments, weakening of muscles, and definitely deformities. So we no longer hunters and gatherers like the past. And if you look at it, people who work outside and they are more labor, kind of like blue-collar workers. They don't tend to get as degenerative changes as white-collar workers do. On the other hand, you have the extreme sports people, where I remember I used to play A-grade soccer, but we used to train like twice a week in United Talaba. But now my kids, who are no way near professionals, when they practice rugby, they train every day for several hours and they destroy their joints. So that's the other extreme. So everything with moderation is ideal. Healthy lifestyle, walking outside. What doesn't make sense to me, and that's my personal opinion, that people tend to sit in a gym smelling sweat of other people. Why don't you just go outside and walk? Walking is the healthiest exercise, and walking, swimming in Australia is the best place for that.
Thank you very much. For anyone who wants to ask questions, either to raise hand or to unmute yourself and ask a question, we do have a few minutes to ask the speakers. Go ahead, please, everyone.
Can I ask a question?
Go ahead.
Any of our guests, what's the impact of osteoporotic bone on your replacement? How much this adjust, or how much does need adjustment of your placement in osteoporosis?
Well, maybe Yasser answer that question. Yasser, you're right.
Yasser? Dr. Yasser?
Yasser is muted.
Dr. Ali?
Dr. Ali, can you take that question?
Okay. Well, I'm happy to answer that question if nobody's answering. I mean, if you notice in my talk, I specifically mentioned that there are three types of patients. There is the good patient, there is the average patient, and there is the bad patient. The good patient is a female young person. The average patient is a male patient, because they don't get osteoporosis, but they are not as smart as females. And then you have the bad patient. The bad patient is usually osteoporotic female patient. And that is, unfortunately, is a major factor for influencing the outcome of any kind of arthroplasty. If you have a platform that is very bad with the osteoporosis, no matter how good is the surgery, no matter how good is the surgeon or the technique, you will struggle because the platform is not as good. So you have to use alternative measures by use supportive techniques or implants. So you use a bigger implant, much more invasive technology, or use additive materials such as cement to augment your fixation. So osteoporosis play a massive role in any outcome for arthroplasty, basically.
Right. Excellent, thank you. Any other questions?
And just to add an osteoporosis in the spine, the thing is every patient, we have to check their bone density. The problem is because even in the spine, when you try to correct deformity or when you try to even fuse the spine, you rely on the fixation of the anchor point, which is the screw anchoring into the bone. So if the bone quality is not good, you cannot do it with this. So we always patient with the cutoff for us is osteopenia, moderate osteopenia. If it's severe osteopenia to osteoporosis, then those need to be optimized and their bone quality have to be improved before considering any major spine surgery for them.
Thanks, Dr. Ali. Any more questions from anyone who can raise hands?
I have a question, Dr. Mohammed.
Yeah, go ahead, please.
Is Isa Mutter? Just a question to Professor Al-Mudarris. Is about you mentioned that there are a lot of orthopedic surgeons avoiding doing a lot of total hip replacement, and you're doing more than 70. Is there reluctance because of complication or experience? What's the cause behind that?
No, it's not the reluctance. What I said is that the majority of joint replacements are done by, like half of the joint replacement are done by surgeons who do less than 10 a year. We have, in different cities, we have concentrated practices where you have highly specialized surgeons that do the vast majority of joints and do mainly joint replacement. So there is only 4% of surgeons that perform more than 70 joint replacements a year. But that doesn't mean that people are shying away from doing joint replacement. It's just the way it is with the referral base. GPs and physiotherapists tend to refer to the most popular surgeons, basically. And it's like anywhere in the States, it's the same. Australia is becoming similar, where the distribution of the joint replacement is happening in concentration of centers around major cities, unfortunately. As you can see with the division in the public and the private sector, majority of the elective surgeries are done in the private, and for many reasons. And these private hospitals, the vast majority of joint replacement happen in very limited number of hospitals around Sydney, for example. I can't talk about other states, but it's no reluctance. As a matter of fact, with hip replacement, knee replacement, and even with ankle replacement, it's becoming very, very popular. Definitely, the science and the evidence-based medicine has showed that joint replacement in hip and knees, for example, works very well with high predictability. And ankle replacement will come very soon as well.
All right, excellent. Well, on behalf of the Educational Committee of IAMA, I sincerely thank all of our speakers. A very good evening, very fruitful, and we learned a lot. Dr. Ahmed, do you have any comment before we close?
I'd like to join you thanking our presenter. It was an excellent webinar, actually. This recording will be on our YouTube channel in a few days. This channel is open to all your presentation, even the personal presentation, the promotional presentation that you want. We can add it to this YouTube channel. And we will add, I think, a separate presentation for Dr. Yasser to just complete the benefit of the presentation. Thank you very much.
Thank you.
Thank you very much to everyone. Thanks for your time, and have a good night. Thank you very much.
Dr. Mohanad?
Yes, go ahead.
I missed thanking our colleague from UK. We were joined by a few colleagues from United Kingdom, Dr. Ali Kubba, and there are a group of colleagues joining from UK. I think Dr. Ali Kubba is still here. So many thanks.
I can say we're very impressed by the young talent from Australia. We're all rather oldies in the UK, so it's great to see Professor Munjid and the others, and it is a delight to be part of your meetings.
You are more than welcome, Doctor.
Thank you
More
very
than
much.
welcome.
Thank you very much, and hopefully, I think there was one highlight, Dr. Ahmed, that perhaps a couple of the neurosurgeons showed interest to present about a neurosurgery as the next webinar, and I'm very looking forward to that.
We agree to talk to them. Thank you very much.
Yeah,
Thanks, guys.
perfect.
Lovely
Thank you
having
very much. Have a good night to everyone.
Thank you, everyone.
Shukran jazeelan.
Thank you.
Good
Thank you.
night.
Bye-bye.
Bye.
Dr. Ali, thank you very much. Thank you. Bye-bye.
Thank you.
Thank you.
Thanks, everyone.